Good afternoon. It's an honor to present at this conference. Thank you, PK, for inviting me. Those are my disclosures. Atherectomy devices, we have them for almost 30 years now with a lot of experience in that field. But unfortunately, there is still no data to guide practitioners in choice of the device. And that is reflected in 2018 AUC for PAT interventions from ACCHA. And some even question the role of atherectomy in any current management paradigm. And the question is, do we need atherectomy in the era of DCB? So, but all seasoned operators, they know that atherectomy does address clinical challenges, especially in complex and calcified lesions. And when in the femoral popliteal segment, it's always good to avoid stenting. And atherectomy does help with vessel preparation. It modifies vessel compliance and possibly improves the drug penetration into the vessel wall. So why remove calcium? Calcium is heavily present in peripheral lesions, and presence of calcium necessitates greater balloon pressures. And we know that calcium might also influence drug-coated balloon efficacy. Expert consensus panel suggests that atherectomy should be considered as part of the SFA treatment algorithm for cases of severe calcification. And this is the results of the data published by Dr. Fanelli, who is here in this audience, and this paper became very famous now, who reported that in patients who were treated with drug-coated balloon, at 1 year, greater calcification was associated with lower patency rates, lower ankle brachial index, greater late lumen loss, and TLR rate. So we have many atherectomy devices on the market right now, and you can put them in several categories: rotational atherectomy, orbital atherectomy, directional atherectomy, and laser atherectomy. Again, unfortunately, not too much comparative data between them, and it's very difficult for an operator with the small procedural volume, or for the fellows who recently graduated from their programs, sometimes to figure out which device to use in different clinical scenarios. So let's look at the data that we have available. This is available solo atherectomy data, and we see that most of the data that we have, more or less decent data, is on directional atherectomy with almost 800 patients studied in definitive LE study. When it comes to orbital atherectomy, like compliance 360, only 25 patients, calcium 360, 25 patients, OS is 124. For the jet stream atherectomy, which is pathway in the past, 172 patients. Cello trial laser atherectomy 65, and Excite ISR, it's laser for instant restenosis, only 169. And not even all the studies had primary patency rates at 1 year reported. But what we learned from the studies is that when you use atherectomy devices, there is a low rate of bailout stenting and a low rate of significant dissections. Moving forward to the DCB era, this is a trial that was run by Dr. Zeller, who is here again. It was a prospective multi-center randomized trial comparing directional atherectomy plus DCB versus DCB alone. And there was a higher technical success rate and lower incidence of flow-limiting dissections were observed in the directional atherectomy plus DCB arm. What we also learned from this study is that directional atherectomy is especially beneficial when it's used in long lesions, when it's more than 10 centimeters, and as well as heavily calcified lesions. The increased lumen gain with directional atherectomy before DCB also resulted in improved patency rates at 12 months. That's why it's very important to get serious about the way you do your atherectomy and try to achieve this less than 30% residual stenosis after atherectomy before you use your DCB balloon. It also impacted the impact of a lumen gain also was seen at 2 years with the trend towards lower TLR rates when residual stenosis was less than 30%. Another data on a jet stream, it's a rotational atherectomy. Bill Gray did this study when they studied the effect of this device in moderately to severely calcified peripheral arterial disease when they looked at calcium removal by IVUS. And what they reported that calcium reduction resulted in 70% increase in lumen area when you use this device. So this device is also good for increase in luminal diameter as well as calcium removal. So what about comparative study? This is our study when we did a randomized trial comparing orbital atherectomy versus directional atherectomy using angiographic and ultrasound outcomes. We enrolled 60 patients, 30 patients in each group. We did IVUS before atherectomy, IVUS after, then used DCB and did IVUS again. For primary endpoints, we looked at the change in plaque volume as well as change in luminal volume and change in angiographic stenosis. Secondary endpoint were device success rate that was defined as a reduction in angiographic stenosis to 30% or less, and as well as rate of Babaev outstanding. So device success rate was higher when directional atherectomy was used, and as well as a number of patients that required stenting after directional atherectomy and DCB was lower in the directional atherectomy arm, is 7% versus 33%. So what we also saw that there was a greater reduction in stenosis following directional atherectomy compared to orbital atherectomy. And this difference persisted after DCB. Directional atherectomy also reduced plaque volume more in the entire lesion compared to orbital atherectomy by IVUS. When we followed these patients for 24 months, looking at revascularization and restenosis rates, in all patients, we saw that there was a numerically lower restenosis and revascularization rate in patients who were treated with directional atherectomy. When we separated patients who were stented and looked just at the non-stented group, we observed a 20% absolute difference favoring directional atherectomy in patients who were in terms of restenosis rates, and as well as 14% absolute difference favoring directional atherectomy in terms of revascularization rates. So in the summary for the trial that compared to orbital, directional atherectomy demonstrated a greater plaque volume reduction and luminal gain with significantly fewer stents needed for post-DCB. And at 24 months, we observed numerically higher restenosis and revascularization rates in orbital compared to directional atherectomy group that did not reach statistical significance. We need larger studies, of course, and longer follow-ups to further evaluate observed findings. And in general, we need more comparative data and randomized trial. Not sure if that will be done, though. Thank you.